Cast is now starting. All attendees are in listen-only mode.
Good morning, everyone, or afternoon, depending on where you are. My name is Kyle Stoker. I am the training director for the IACA. Thank you for joining us for today's webinar. Before I turn it over to Dawn, really briefly, everybody else is muted. If you need to ask a question, you can type it into the control panel. If you have a comment or a question about the system itself or training or something that's not related to her topic, there's also a chat box that you can type into, or you can send me an email at training@iaca.net. Tomorrow you will get an email from Citrix that has your certificate, and it will also link you to our evaluation system. So we'd appreciate it if you'd go through and give us some feedback. Like I said, if you have any questions, go ahead and type them into the chat box. We'll take those all at the end. And if you have anything else, just like I said, send me a chat message or send me an email and I'll be happy to help you. All right, Dawn, are you ready?
I sure am.
All right, take it away.
All right, thank you, Kyle, and thank you all for taking a little bit of time out of your day to learn about this very important topic. I appreciate you being here, and hopefully you walk away with some really quality tools that will help you and your agency move forward in your goals. So this training is called Using Analytics to Divert Frequent Utilizers from Justice-Based Systems into Effective Treatment. So the training focuses on utilizing data, coordinated support systems, and systemic services to divert individuals with mental health and substance use disorders to appropriate treatment and services in your community as they cycle through crisis. So these individuals overlap a multitude of systems, including your police department, jails, hospitals, social service providers, and so forth. And they impose enormous and reoccurring costs. So there's two key components, the timely identification and coordinated services. So two big things we're going to talk about, that timely identification and coordinated services. Those two things will better serve frequent utilizers and divert them from the justice-based systems into effective and proper treatment. And so I should say I'm Dawn Reby. Thank you for being here. My information will be at the very end of this slide if my name hadn't popped up in the beginning. But what we're going to do today is talk about some key concepts. We're going to dig a little deeper into understanding the problem at hand, and I'm going to point you to some research that really opens our eyes to the magnitude of this issue. We're going to talk about building a data sharing culture. Imagine that. We all talk to each other, right? So this data sharing culture and infrastructure with both internal partners and external partners. We're going to dig in and identify the data needed to drive decisions in strategic operations that are going to essentially best serve this population. So specifically, we're going to determine what type of law enforcement data that is most helpful. And then I'm going to introduce another idea that's non-law enforcement data. So examining other sources of information that could be super helpful for the analysis of this issue and essentially the strategy development around this issue. We're going to talk about key areas of analysis. So once you have your data, how do you identify frequent utilizers in your community? How you look at the key characteristics of frequent utilizers and service needs? Maybe even looking at frequented locations, regional law enforcement analysis, a cost analysis, and building a robust analytical product. Like you have all that great information, you analyze all that great information, and now you produce a great product that helps move forward in reaching your goals. We're going to talk about what it means to build a coordinated system where individual intercepts are more likely to lead to a connection to appropriate and effective responses. We're going to explore gaps that we discovered when I was in a partnership with the Middlesex County Sheriff's Office in Massachusetts and Arnold Ventures when we met face-to-face with our 54 police partners. 54 police agencies. We met with most of them. So I'll share some of the insight relative to that. So through these site visits, we also learned great best practices that I'm going to share with you today as well. So I will say, if you have a question, please type it into that question box there. I'll do my best to go back and forth and look at the questions. And if I don't get to your question right away, please know that we are going to take a little bit of time at the end of this training and make sure that we answer all of your questions. Okay. So the first step here is to understand the actual issue at hand. Let's understand our problem. In order to better understand the type of intervention to best serve the frequent utilizer population, we first need to understand the population itself through frequent utilizer analysis. By taking a more holistic, cross-disciplinary approach, it's important to support efforts that are already underway, right? There's so many good things that are already happening, by knitting together and gap-filling diversion and treatment services for these individuals and providing data to identify the most needed and lacking services. So these frequent utilizers can be defined or described as individuals with mental health issues, substance use disorder. They may or may not be experiencing homelessness. They are frequently interfacing with law enforcement, jails, first responders, and healthcare providers such as emergency departments at a hospital, mental health providers, that sort of social service provider network. Frequent utilizers are those individuals who cycle between emergency rooms, homeless shelters, drug treatment facilities, police lockups, and local jails. The lack of coordinated care not only fails to address the underlying health issues that drive people into these systems, it actually perpetuates a never-ending loop of costly and ineffective responses. We're going to change that today, right? So Arnold Ventures conducted research and produced a 2017 annual report, which is where this chart is sourced. The one that you're looking at is sourced. They noted that 11.4 million Americans cycle through our jail systems, and while there, often receive fragmented and uncoordinated care. This results in poor outcomes and over $20 billion in cost to taxpayers. They then did a breakdown of those who are in our jails and who are diagnosed with and without mental illnesses, substance abuse disorders, and chronic health problems, as you see in the charts displayed here. Their report, their 2017 annual report, indicates that more than 60% of the 11 million people who spend time in local jails each year have a mental illness or substance use disorder. An additional 44% have chronic health issues. Jail systems don't often have the training and resources they need to respond to these conditions, and time spent behind bars can actually make folks worse. People end up cycling through jails, emergency rooms, and social service programs. Arnold Venture continues in their report, a lack of coordinated care not only fails to address the underlying healthcare issues that drive people into these systems, it perpetuates this never-ending loop of costly and ineffective responses. So NAMI, the National Alliance on Mental Health, has similar findings in their research, and they report that the vast majority of these individuals are not violent criminals. Most people in jail have not gone to trial yet, so they're not even convicted of a crime. The rest are serving short sentences for minor crimes. NAMI reports that once in jail, many individuals don't receive the treatment they need and end up getting worse, not better. They stay longer than their counterparts without mental illness. They are at risk of victimization, and often their mental health conditions get worse. So for those who don't know what NAMI is, if you're dealing with the mental health community, this should be one of your resources that you're going to on a regular basis. Their sources down the bottom there, the National Alliance on Mental Illness. And so they are the nation's largest grassroots mental health organization. They're dedicated to building better lives for millions of Americans affected by mental illness, as their website indicates. So they do quite a few things. They educate, so they offer a ton of educational programs to thousands of families, individuals, and educators, right? Pumping information to them. They advocate. They actually have a helpline, so they listen. It's the NAMI helpline, and it allows them to respond personally to hundreds of thousands of requests each year, providing free information and support in a much-needed lifeline for many. And they also lead a bunch of public awareness events. So if you haven't already gone to their website, make sure you visit them. One program that is particularly helpful for law enforcement is their Stepping Up initiative. This initiative aims to reduce the number of people with mental illness in jails. So they host monthly broadcasts and webinars. If you haven't already, hop on to their website, learn a little bit more, see if you can get onto their broadcasts and webinars monthly to learn about different best practices that are happening right now throughout the country to serve this population. So the Harvard Kennedy School provided preliminary reports back in April 2018 from lessons learned through a Camden, New Jersey study that involved, now this is a little bit different, so it involved the integration of healthcare and criminal justice data for people who cycle in and out of hospitals and police precincts in Camden, New Jersey. So this is a particularly unique study as they actually had data from both hospitals and the criminal justice system, and they were able to identify and analyze the experiences of people who showed an extreme number of contacts with both systems, right? So that the CJ system and the mental health system, the hospital system, were talking to each other. So in figure 1 from the study, you can see that 67% of individuals overlapped across police and hospital services. So interestingly, the study suggests that we should shift from a mindset of reacting to immediate health and crime crisis as distinct events to rather focusing on a holistic approach that results in better individual outcomes, increased public safety, and reduced system costs. So the holistic view provided by integrated data would allow researchers, policymakers, practitioners, etc., to design early interventions to prevent crime and avoid using jails, police, and emergency departments as a response. Okay. So we know that there have been several national studies on the extent of this issue, like we just talked about, and that describes how this problem impacts taxpayers and suffocates the criminal justice and social service communities. But what does this mean every single day for a police officer, right? So there's lots of folks here that work for police agencies. So what does all that big level of research mean for us on the day-to-day level? Well, it means money, time, and frustration. I had the pleasure of working with the Middlesex Sheriff's Office under a grant from the Arnold Ventures, where we worked to establish a system that would integrate 54 police department agency data as well as hospital and EMS data into one platform for analysis. During our site visits to the dozens of police departments, the agencies continue to reveal, probably something that you already know, their frustration as they continuously responded to the same homes, the same individuals, delivering them to hospitals for services over and over again. So, however, these individuals often returned home, sometimes even before the officers do. Officers in our 54 police agencies felt like they were spinning their wheels. And it's likely that you might be feeling the same way. The costs to police agencies are extraordinary. We looked at the data of 10 police departments. So we took 3 and sometimes 5 years of data for 10 police agencies in Massachusetts and found that the average of 15% of all of the calls for service, so 15% of all of your calls for service or their calls for service were related to only 2% of the population, and that most of the calls were mental health related responses, and they required a lot of time. So there was 2 components there. The 15%, right? So 2% of the population was responsible for 15% of the calls for service. But the bigger underlying issue or the bigger part of this is that they weren't just calls that you went to for 2 minutes. There were calls that you went to and spent a significant amount of time on. So the time analysis piece is important as well. So what does this all look like in real life, right? I just gave you a bunch of numbers and statistics, and what does this look like in real life? So I'm going to share with you a story about a man named Joe. Deputy Superintendent Dan Wagner of the Cambridge, Massachusetts Police Department shared this slide with me as well as the story. So let me share this story. This might resonate with some of you. And if it does, you can go ahead and write in the little questions section. This is my life, right? So what does this look like for you? So Joe is a homeless man with severe alcoholism and health problems. He's well known to the Cambridge Police Department in Massachusetts. Of the 116 incidents that officers have logged in their case notes, many follow a familiar pattern. Over and over again, officers are called to assist Joe in getting to a shelter or hospital where he is no longer able to get there himself. So from 2013 to 2018, case notes indicate that Joe has been arrested only once, right? So in this part of the country, we really have this strategic effort to not arrest folks, but really to treat them. So in all of this time, he has only been arrested once, part of that concentrated and strategic effort by the Cambridge Police Department to connect him with services, with treatment. So because of his substance use issue and what officers suspect is an undiagnosed mental health issue, efforts to get Joe a neurological evaluation have been fruitless so far. Joe also has many physical health problems. Officers have picked him up. Now listen to this. Officers have picked him up after he's fractured his leg in 3 places, when he's suffering from hypothermia and frostbite. Okay? And so his case notes detail countless trips to local emergency departments for these conditions and for extreme intoxication. In just 6 weeks in 2017, Joe was taken to the emergency department. Ready? In 6 weeks, Joe was taken by police to the emergency room 38 times. Wow, that's a lot of police time. Over the course of 2 years, which you see here in this chart, in 2016 and 17, he had 371 EMS transports, with an average of 3 EMS transports every 4 days. Officers, hospital staff, and shelter staff want to find long-term treatment for Joe, but they're struggling to figure out what the solution looks like. He has been Section 35, which is an involuntary hospitalization for substance use disorder, more than 8 times in the past 5 years. But those experiences and treatment programs have been too short to provide long-term help. Does that story sound familiar? We know that the most likely solution to Joe's challenge is much more long-term, effective health and mental health care and supportive housing. But until those solutions are identified and deployed, police, and this is the key, police will remain on the front lines of response to these complex social service issues. So let me just explain what this chart is, and you let me know if you have a Joe in your community. I guarantee that you have someone just like Joe. So the way this chart is broken down, we have 2016 up at the top and 2017 down the bottom. The green C is for when Joe was civilly committed. So you can see that a large portion of these 2 years, he was civilly committed. And then the yellow markers with number 1, that's how many times he was transported per day in that day to via EMS, right? So this is EMS data as well. And then the gray is when he had no activity at all. And you can see the progression. So the yellow ones are he was transported once. And then the orange 2s means that he was transported twice to the hospital in the same day. And then the red 3s indicate that he was transported 3 times via EMS to hospitals in the same day. So let's take a look at the last half a year of 2017. You can see this progression. He was civilly committed. Then the day that he returned from his commitment, he was transported to the hospital 3 times. And then you can see this cycle of going back to the hospital on an average of 2 times a day, then getting civilly committed again, and then going back to the hospital over and over and over again. So on average, the transports in the last 2 years were 3 transports every 4 days, okay? And so, and I argue that if you actually looked at the last year, you could raise that number quite a bit. So the average looks more like, 3 or 2 on each day itself. And this is quite significant. Okay, so now we know what the problem looks like. So as you're thinking about what the problem looks like in your community, you can start to think of, we're moving into how can we build this data sharing culture. You might only have access to your police data, but what would happen if you had access to your EMS data, your hospital data? How would that look like? And so I'm going to share with you what we did. So between the work we did in Middlesex County, Massachusetts, the studies by the Arnold Ventures and NAMI and the Camden study, and by sharing the story of Joe from Cambridge, Massachusetts, and likely from your own experiences, we can certainly recognize that this challenge is real and that we must establish coordinated systems of care to truly understand and serve this population. Okay, so it starts with partners and stakeholders. And this is a biggie, right? We talk to each other. So who are our partners? Yes, we can talk to each other. This stuff works when we collaborate. So the first step is to start with the building a data sharing culture. Building a data sharing culture and infrastructure with internal and external partners is not easy. There's HIPAA and CORI and fears and technology that all come into play. We must understand and utilize the information that we have to properly assess and address this population through systems that work. And we must talk between agencies and systems for a holistic approach. So how do we do that? First, we identify who the stakeholders are, okay? So this is kind of that DDAX approach. If you've heard of DDAX before, one of the key pillars is partners and stakeholders. So here's what we do first. We identify our stakeholders. The first step that we took in Middlesex County was to identify who to bring to the table. Our initial stakeholders included the Association of Behavioral Health Providers, advocates, and they are a prominent behavioral health provider in our county, individual jail diversion clinicians. We actually are lucky in Middlesex County. We had those jail diversion program clinicians embedded right in our police agencies, or many of them, I should say. Our partners, our police partners, the 54 police agencies. We had the Mass Health and Hospital Association as a partner, Massachusetts League of Community Health Centers, Medicaid, Mass Health, ambulance providers, the Mass Association of Ambulance Providers. Then we had separate EMS providers, emergency response providers, such as Trinity, Fallon, Pro EMS. So we had a Middlesex County Restoration Center Commission as a partner, the Metro West Opioid Addiction Prevention Collaborative, Cambridge Police Department stakeholder meeting, all those folks, and then of course the Mass State Police. So we then so first step is to figure out who the partners are. So if you're thinking about how do I do this in my agency, I first got to identify who I want to bring to the table. What are the right people to bring to the bus, right, or on the bus? Then we establish stakeholder partner agreements with the assistance of attorneys, right, assigned to the Data-Driven Justice Initiative. So we outlined exactly what all partners were, what they were all looking for, what we were looking to accomplish. We identified key responsibilities, and we brought everyone to the same page by having folks sign a data sharing agreement, a partner agreement rather. So next, we established the data sharing policies that included where the data would be stored, who would receive analytics that involved HIPAA data. So when we compiled the HIPAA portion of the data, we wanted, HIPAA people to get that information, which would be the clinicians who worked within the police agencies. So we'd have to strip the data of the HIPAA portions of it to deliver it directly to the police agencies. So the data sharing policies helped us also to identify what types of analysis police would receive. What would be helpful for them? What would be helpful for their agencies? What regional information we could draw, from all of these data sets that would be helpful for police agencies and more, right? So we really talked about what does it mean to share information and what information do folks want. So after listing our stakeholders, developing partner agreements, and establishing data sharing policies, we then started the engagement process. We went out to all of our police agencies within the county to establish buy-in. We worked with 10 pilot agencies to extract 3 years of calls and RMS data, records management data, from each of the police agencies. We then delivered an analytical product back to the 10 pilot agencies specific to their own data. And we also included regional analysis and jail data too. So if someone was a frequent utilizer in their community, we compared them to the other 9 pilot agencies, which included the jail data. How many times has this person been in jail? So this analytical product, although it was quite basic at the time, it provided insight as well as the vision of opportunity that data sharing brings. It identified opportunities to equip law enforcement and first responders with the tools they needed to safely respond and divert individuals to appropriate treatment and services in the community as they cycled in and out of crisis. So here's an image of the Middlesex County that we use to actually track our partnerships with police partners here on the left-hand side, and jail diversion clinician partners over here on the right-hand side. Okay, so the baseline was completed in year 1 of the project, and I'm really looking forward to seeing this effort continue as sustainable partnerships are essential to creating that cultural shift. Okay, so we talked about big picture, we talked about partners, and now we're going to move on to data sources to consider. So this is the data collection section. So we want to identify specific pieces of data that are going to be helpful in our analytics. So here we explore the data that's needed to drive those decisions and strategic operations to best serve this population, data-driven strategies. Specifically, the next step for once you identify partners and set up those agreements is determining what types of law enforcement data are most helpful, and also examine other relevant data sources. So our project involved data from EMS, from local hospitals, from our 54 police partners, and from local service providers. So even though we had access to cross-discipline data sources, most police agencies don't, right? So if you're sitting there and you're saying, hey, I work for my one police agency, there's still stuff that you can do, right? We can still conduct quality analysis on our own information within our own police agency's data that will still identify frequent utilizers and related activity. So here's some information to consider. To begin, analysts. So what can you do as an analyst in your agency? As an analyst, you can establish a person file, right? The first step to all of this. Establish a person file that includes all persons involved as a suspect, a defendant, a victim, a witness, or any other, whatever variable you have in any CAD call, incident, arrest, or event, maybe for the last 3 to 5 years. So you don't want to just do arrests, because in this northeastern part of the country, if you just did arrests, just like in that Joe case, he wouldn't have risen to the top as a frequent utilizer because he was only arrested once. So in this part of the country, and you can decide what's right for you, but in this part of the country, I say don't only use arrest data. Certainly incorporate it, but don't only use arrest data. You want to take, if you don't have already, your arrest data, your incident data, your field interrogation data, your CAD data, and combine it all into one master person file. So now you may be working with completely separate CAD and RMS systems or technologies that separate out your incidents versus crimes versus field interrogation reports. Your vendor might automatically put that in together in one place for you. Wherever you are in this process, what's important to know is take the time to create this single file that creates your data. You can do this through an append query in Microsoft Access, probably a series of append queries in Microsoft Access. If you're like, what the heck is an append query in Microsoft Access? IACA and iAnalyst have great trainings on how to append your data using Microsoft Access. So you can go ahead and search all the other trainings that are available, and we're more than happy to share those with you directly if you like as well. Okay, so here are some variables that you would include in your person file. So you'd want your first name, last name, the social security number. I put that in there, but certainly if you have another key identifier, some departments have like an ID number that they generate versus a social security number. whatever it is for you, get that unduplicated number in there. At the age at the time of an incident, arrest, or event, the race. It would be really great if you had some translation library tables as well. So you'd have your race numbers in there, and then you'd have what the numbers actually meant. So like 1 would be white, 2 would be, whatever. Ethnicity, again, with code translations. Gender, male, female, with code translations if possible. That one might not be as necessary as some of the other ones, but certainly translation tables certainly help. You'd want the home address, whether the individual was homeless or not, your report number, your booking number, CAD incidents, like why you stopped them, why you arrested them, why they called 911, why someone else called 911 on them, and so forth. The date of the incidents involving. So here's something interesting. If you have access to this data, I would recommend taking a look at the time that the call was initiated and the time that the call was cleared. When you do that, you're actually able to look at how much time your department is spending on mental health calls or individuals who have, who are frequent utilizers, how much time you're spending on calls with them. Type of police contacts, the role. This was a fun one to analyze. The role that the person is taking in each of these incidents, arrests, and events. Are they the suspect? Are they the victim? We had a woman who was a victim 96 times, and she never rose as a frequent utilizer for the agency because she was never an offender. So, so certainly look at the victims, right? You can be an overdose victim depending on how you qualify your data. So take a look at your suspects, victims, witnesses, etc. The locations, whether or not there's drugs involved, mental health involved. These were the categories that we looked at, but you might have access to more information, so feel free to go wild. So I will say that you can also establish an unduplicated file of calls for service if your calls are separate, an unduplicated file for calls for service and reports that can be later used to identify top location. So this is really dependent on how your department sets up your data. So if you have 2 different files, get your person file and get your CAD file. Okay, so now you have all the data in your police agency that you want to analyze. So how do we do that? Once you get your data files, now it's time to actually analyze. Here are some key areas, and you can print this out or take a screenshot or something and print it out and just walk through it. Like walk through, will this work for my agency? So answer the questions. How do we identify frequent utilizers? Will these be people involved in specific types of calls or incidents, or will we just do everybody, right? Will you create a weighted system where you give more weight to the recent contacts or to specific types of contacts? So maybe you give more weight to anything drug related, or maybe you give more weight to anything mental health related if possible. So that's up to you. Those are some questions to ask. Will you define a frequent utilizer in your department as more than 2 contacts, more than 5 contacts, more than 10 contacts, more than 30 contacts? So starting to get a feel for what is a frequent utilizer. And this can really depend on the size of your department and the data that's available to you. An analysis that could help with this would be identifying our frequent utilizer counts. So, how many crimes, incidents, reports were these folks involved in? And those can be a simple aggregation query. You want to look at the percent of population that your frequent utilizers make up. So do our frequent utilizers, are they similar to the Middlesex County project where they make up 2 to 5% of the population? What percentage of contacts for which the frequent utilizers are responsible? So are your 2% population responsible for 15, 20, 30% of contacts that you folks have with them? What do the average contacts look like for frequent utilizers? Are they, responding to drunk calls? Are they check condition calls? Like, what are these calls looking like for you? What are the key characteristics of frequent utilizers and service needs? Right, so one community might have a ton of group homes in their community, and so their service needs or age group or that kind of thing might look different than a different community who doesn't have all those group homes. So let's look at some key characteristics you have at your agency or in your city or town. Frequented locations. So get this on there. Maybe this goes out in your bulletin as like a little spot, a little dot that says, hey, frequent location, our mental health or our frequent utilizer, frequent location is, you know, pick of the week kind of thing. Special attention to this area, making it actionable. Performing a cost analysis. Once you identify how much time an individual takes up, right? So you have the number of calls that you've responded to involving these frequent utilizers. You have the time on those calls, so you can do the math there. Then you can take your budgets and say, okay, how much do we pay an officer on average? Let's times that by the number of calls or the time on calls and really get a cost analysis going. Your commanders might really like to look at this in terms of numbers and costs. Building a robust analytical product, right? So creating a product, think about how can you make your analysis actionable. If you push out a bunch of numbers and statistics, I mean, that's fine, but that really isn't actionable. So making your product actionable, go to this location, visit these 10 people, like creating action, telling your officers how to use their time most efficiently by looking at X amount of people. Or maybe it's not telling your officers, maybe the action is to your clinicians and providing them a list, right? But we'll get into that in a second. Maybe you perform some case studies. Maybe you perform a case study like Joe and really look at how that looks in your department. And then think about how you're going to disseminate your findings. How often do you want to push out frequent utilizer information? Who do you want to send that information to? Who are your partners in your community that could benefit from this information? That could essentially lead to the better services provided for these frequent utilizers. So the data analysis piece really involves these key focus areas. All right. So print this out. It's kind of your roadmap. Check it off as you go, and you know, provide this value for your police agency. You probably have access to lots of this information if you're an analyst. If you're a chief or an executive listening to this call, you might say, you know, yes, our analyst has this information, and this is the work that we want them to do. If you're a clinician listening to this call, maybe you have additional ideas that you want your agency to provide to you if you in fact work directly with them. And if you don't, maybe you want to establish a partnership as a result of listening to this webinar. Okay, let's move on. So what does it actually look like? So I'm going to go through just a couple of slides of what these frequency slides can look like. And if you're working in Microsoft Access, this is what it's going to look like for you. We won't spend too much time here, but I will say if you are interested in digging down to exactly how this could look in terms of the analytics, like the 1, 2, 3s, when you receive your survey tomorrow or the next day, when you receive your survey, there's this space in there to say, you know, here's the type of training I want. You can go ahead and plug in there, hey, I want to know exactly how to do it. I want to know what an aggregation query is and what a cross-tab query is and how to utilize these tools to conduct this analysis. Okay, so I'm going to give you a quick look of what it could look like. Here's a simple aggregation query for a community that we worked with, and we selected a 3-year time period or 2.5-year time period, and it was greater than 10. So we wanted a number of involvements was greater than 10, and it was as simple as this. And here was the output during this time period. And we simply gave this to the department along with the other analytics. So this is an aggregation query. Here's a simple select query. So here we wanted to know a particular individual, you know, this returns the activity of selected folks. So what was this person involved in versus just giving the number. You want to know what this person was involved in. You can go ahead and look at it one by one like this. When were they arrested? What were they arrested for? And so forth. It's a simple query. And if you notice here, we have a little expression for year because we didn't have year in our data, so we had to build out an expression. Again, there's trainings through the IACA, through Analyst for how to create expressions. So you can go ahead and take a look at some of those as well, if that would help you. So we also ran a crosstab query. We set this up ahead of time. Our top utilizers, I would literally just plug in the social security number and bam, the output would come up. It resulted in all of these activities that this particular individual was involved in as a victim, witness, offender, or whatever that might be. So we had a couple of core core queries rather that we worked with to produce the analytical products. You might also consider looking at your top locations. So once you have your frequent utilizers, right, in this case, they were listed as mental health, we wanted to know where were these individuals often located. So instead of doing just a simple top location aggregation query, we wanted to know of the frequent utilizers listed as mental health, where were they most often located? And we came up with a couple of addresses that we could develop some strategic operations around. And those are fake addresses, but it gives you the idea. Here's another way that you can share with your department how to analyze this information. So this is a powerful, powerful, powerful slide, right? So if you take a look at this, this is one person's involvement over the course of a year, right? Or a couple years. And so really looking at how many contacts this individual has had in this example using PowerPoint. It's a free download, PowerPoint timelines. It's a free download. You just plug in your information and it populates this for you. It takes a few minutes to do. If you have some timeline software, go for it. We did not, so everything I did had to be for free. So this was the PowerPoint timeline was free. So you plug in the information and bam, out comes this chart, and people can look and say, wow, we've had a ton of contacts. Now let's move on to some of the analysis, because this is someone I want to focus on. So you can do an intervention piece here, like let's say your intervention started in April, you could have a line right in there in April and take a look at the cases that this person was involved with after your intervention with that individual. Okay. Let's talk about sequential intercept mapping or bigger picture strategic operations, building a coordinated system of care. So we're shifting. I know that was a quick shift. We talked about data analysis, and now we're shifting to, we have all of our great analysis. Now what do we do with that information? How do we develop strategies with that information? Analysts often skip out of this part, and I encourage you not to. I encourage you to be the expert of the data and provide your expertise in this process, okay? And so I'm going to show you how to actually do that. So once you get your files, now once you get your analysis rather, now you can go ahead and analyze your information. Put it into this sequential map here. So sequential intercept mapping is a dynamic, interactive tool for developing criminal justice mental health partnerships used by communities to assess their resources, their gaps, and opportunities at each of the 5 intercept points. Okay, so law enforcement is at intercept 1. So the group gets together and they look at all of these intercept points. The mapping exercise aims to identify potential opportunities for diversion or alternative justice and behavioral health interventions for the person with the mental illness or the co-occurring disorders with each of the 5 intercepts. And so the 5 intercepts include 1, which is pre-arrest or first contact with the CJ system. This could be in dispatch where they're calling 911 in. It could be where police are actually interacting with them. Crisis center teams, emergency services. So all of that kind of is intercept 1. Intercept 2 is we arrested them, right? So the initial detention, the booking, the arraignment, the court hearing, the referral to specialty courts, the pretrial services, that's all focus area or intercept area 2. Intercept area 3 is the jails and the courts. As you can see from the chart here, I'm just kind of walking through it. Intercept area 4 is prison, jail reentry, prison reentry. Intercept 5 is probation, parole, community supports, housing, vocational support, peer support, and that kind of thing. So the sequential intercept mapping exercise, and it's through, I should note that it's through the Justice and Mental Health Collaboration Program, the JMHCP. So if you haven't heard of this already, here's a great strategy development opportunity. It's a tool for strategy development. So you can go to the Justice and Mental Health Collaboration Program, the BJA website, and find this program there. And they'll actually come out or show you when the next training is and have your agency be part of this sequential intercept mapping if you haven't already. So the sequential intercept mapping exercise has 3 primary objectives. It's the development of a comprehensive picture of how people with mental illness and co-occurring disorders flow through the criminal justice system along 5 distinct intercept points that we just discussed. The second primary objective is to identify gaps in resources. It's to identify actual resources and opportunities at each intercept for individuals in your target population. And the third primary objective of getting your folks together at one of these sequential intercept mapping meetings is the development of priorities for activities designed to improve systems and service level responses for individuals in that target population. So again, go to BJA's Justice and Mental Health Collaboration Program, and you'll find some more details of how to start to work together in partnership with law enforcement and other community partnerships to use the information that you've analyzed and potentially develop those relationship partnerships so that you can look at, or somebody can look at, additional information and develop intercept responses that are most appropriate. Okay. So during my work with the Middlesex County Sheriff's Office in Massachusetts, we identified a series of interventions, many of which built upon services and interventions that already existed in the community. So these services included services that already existed with law enforcement. We found that we had jail diversion program clinicians, as well as other services that existed in the community, like emergency service providers, community health centers. In addition to services that currently existed, we also explored new and upcoming resources, including engaging with a planning commission aimed to explore a crisis stabilization center or a restoration center in Middlesex County, as well as engaging with the state official of Medicaid, Mass Health, as they launch programs focused on their behavioral health frequent utilizers. So we identified a ton of resources, and if you have not already done this in your community, I encourage you to do this. Like, think about, do your officers know what the resources are in your community? Do you know what the resources are in your community, right? So here's what we found. We found, and you can certainly have this as a list in your head. Hey, we have that, or let me go find out if we have that. So we found the jail diversion clinicians, or co-responded. Many of our police agencies had partnerships with jail diversion clinicians who were embedded directly in the police agencies. And they were done so in a couple of different ways. One way would be that they would follow up. So they would get a list of people to follow up with each day or week. Another way that they partnered with the police departments is they would actually go on mental health and substance abuse calls with our police officers. So they would be the treatment intervention at that moment. They would be the crisis diffusion at that moment. And they would co-respond with the police officers. And there's a couple different ways you can do that. Police departments had one clinician. Every single police department that we spoke to that had a clinician with them wanted more. They loved them, right? So they were super valuable. They provided police with the language they needed to get their sections approved at the hospital and that kind of thing. So they were a really valuable resource. And so some smaller agencies couldn't afford their own co-responders, so they reached out with local police departments and they actually hired clinicians together, right? So they had one clinician who would serve multiple police agencies. And so those clinicians are incredibly valuable. The hope is that you are pampering them because they are doing great work for the police agencies. At least they were in Middlesex County. We found PARI, PARI recovery coaches were a valuable resource. We found in Cambridge, Massachusetts, they had Family Social Justice Unit actually in the police department that responded, that did quite a bit. We found in Lowell, Massachusetts, we had a community opioid outreach program. In Tewksbury, Massachusetts, we had a community service unit. Marlboro PD had great resources. We found connections with the hospitals, really great contacts there, resources that were willing to give us lists of, availability, beds, and other opportunities to our police agencies that we previously didn't have. We found Family Social Service Unit, the opioid team, we already talked about that. Our cities and towns, some of them even hire their own social workers. So maybe your town has a social worker that you could tap into and find that as a resource. We found behavioral health units that we tapped into, overdose follow-up opportunities, wet shelter beds that we didn't even know about. We found a meth clinic that we didn't know about, detox facilities. DCF was a good resource, community health centers that were great spots to put individuals. We found helplines. I mean, our officers did not have the opportunity in the past to really provide a list of resources. Now they have a printed card. Some have a printed card of all the resources that are available, the helplines and so forth. DA Marian Ryan has the opioid task force. We have heroin education awareness task force, HEAT. We have the Mystic Valley's Elder Services. Elder Services is a great resource. Connect with those folks in your community. Veteran Affairs, we had a One Mind campaign, a domestic violence advocate. Those were great. We had a ton of great resources that we were able to identify through this project that many of the police departments didn't even know existed. So creating a process of or taking the time to look at an inventory of the services that are available in your community or directly around your community is a valuable use of your time. So in this process, we did identify some gaps. We were part of a pilot project, so we had a pilot going out in California, in Iowa City, in Middlesex County. So we wanted to look at a big community, a medium community, and a small community, and best practices and gaps. So one of the gaps that we found is that we wanted more clinicians to co-respond with our officers. That was the ticket. Clinicians with our officers, more crisis teams responding. We wanted more bed availability, or really a distinction of whether there was bed availability. So many people assumed that there was no bed availability because that's what they heard, but in fact there was. So we wanted to tap into where the beds were open. We decided that we needed more long-term treatment, which I think you're going to find as well, that this is a lifestyle change, not just a detox or a mat. It's the next level of care is beyond just detox. Access to activities can be a cost barrier. Detox can be a cost barrier. We found that there was actually a barrier with prescription coverage. So, for instance, Vivitrol has a 28-day cycle, so the prescription coverage is 28 days, but as you know, some months in the year have 31 days and 30 days, and 4 times a year, there's one with 29 days, not 4 times a year, once every 4 years. And so what do folks do on those other days, right? And so we wanted to really bridge that gap. We found a wait list for services. We found that police were not able to track recidivism. We had no idea what happened to people after treatment or hospitalization. We found challenges around co-occurring substance abuse and mental health. So there weren't a lot of facilities that would take someone with both. So we really wanted to explore opportunities where we could have that co-occurring piece in there. Transportation was a big issue for us, right? So the folks would pay, insurances would pay for folks to be transported to the hospital, but not necessarily to treatment. So working through some of those transportation and insurance reimbursement issues is likely a next step. And then the availability of long-term treatment, we discovered that was, again, to mention it twice, really a barrier. We also discovered some best practices. So the Sheriff's Office, the Data-Driven Justice Initiative, we found that police departments are already taking innovative steps to address individuals with complex behavioral health needs. Middlesex County Police Departments had a long list of best practices and approaches to managing and serving these individuals, presenting an excellent case study in a progressive approach to the frequent utilizer population. I personally was very impressed. So even without extensive data sharing or countywide infrastructure to provide services, individual police departments are already working to take steps to avoid arrest and improve diversion of individuals with mental health issues or substance use disorders. Okay, so for example, most Middlesex County Police Departments include a part-time or full-time clinician on their team to work with individuals. That's a best practice. That's something that worked. Other emerging practices included the use of multidisciplinary teams For instance, Cambridge Family and Social Justice Section, or the Lowell COOP team, they engage frequent utilizer populations. Those teams worked really well. Each team varies in their makeup, but include a mix of police officers, here's the key, a mix of police officers, clinicians, social workers, and other emergency first responders who, ready? Here it is, work collaboratively to provide services and supports to individuals who need it most. These teams helped connect individuals with complex behavioral health and housing issues to more appropriate services, and avoided incarceration and arrest doing so. Another best practice was our Section 12 forms. So here's a really cool thing. I'm going to give credit to a JDP, a clinician. This clinician worked to break down the communication barrier between police officers and healthcare providers, particularly in cases of involuntary commitments, known in Massachusetts as a Section 12. So the JDP clinician created a form, how innovative, created a form for officers to complete and share with a hospital provider when presenting an individual for a Section 12. It helped officers, one, learn and use the language, right? It helped the officer learn and use the language to be able to be effectively communicating their concerns about an individual. We also had another best practice was data integrity and support. So each police department manages their reporting differently. So we did not have one reporting system. We had 54 different RMS vendors, 54 different CAD vendors. It was pretty wild. So we have they have their own data systems, right? Because many of the police agencies didn't have data, right? So because many of the departments have not had to use their data to report out on the interactions with these individuals before, some have no way of extracting this type of data. So at each site visit, we actually at the sheriff's office sought to better understand how how they can record interactions with these individuals, whether in the narrative, through dispatch, call notes, or sometimes they used specific coding for reports. So for departments that didn't either record the interaction or code, we showed them how. We said, hey, here's how you can actually record your information more efficiently and manage your data. And honestly, the feedback was welcomed, and at times they immediately incorporated it into their practices. So for example, one police department implemented an additional code for mental health calls 45 minutes after we left their department. So moving forward, that department will be far better equipped to use their data to better understand their time and resources spent on individuals' mental illness. So the key here is, one, being able to access your data through direct data access, and the second piece is creating systematized codes, right? Systematized reporting systems, that you do every single time. So every time there's an overdose, you report that overdose in a report, not just in your CAD call as an ambulance call, right? So another best practice, we found that JDP clinician, there were actually grant opportunities for them. Over 40 of the 54 police departments in Middlesex County employ a jail diversion clinician, either part or full-time. And many do so through grant funding from the Mass Department of Mental Health. So through the DDJ, the Data Driven Justice site visits, when meeting with departments, we shared information on grant funding that other folks did not know about, and then they got to apply for similar grant funding to bring these clinicians to their departments as well. So we already talked about requiring reports for all overdoses. That was a best practice. If an overdose occurs, write a report. A best practice was using those uniform codes, the same code for overdose, the same code for mental health in both your CAD, come up with a code, and then come up with a code in your RMS system. Incorporating diverse record types in frequent utilizer analysis. If you're able to have access to EMS data, hospital data, even if you don't see it, even if you have a third party look at it with your police data, identifying frequent utilizer analysis with all that data was much more impactful. Another best practice was referral of behavioral health and substance use disorder cases to jail diversion clinicians. So what we did is we produced a list in once a week, delivered it to, well, the idea, we didn't actually do this. This is the idea, is to once a week deliver it to that clinician. And they were excited about that idea. They said, yeah, we would love a list of like the top 10 people that we need to take a look at. The key here is build partnerships first, right? So for a general overall rule is to present the big picture to your partners, right? Build that partnership, that buy-in first. You can maybe think about doing it in a webinar. I mean, we don't often do that in law enforcement. Maybe you can. Maybe put together a short little webinar. You know, here's what the partnership we want to have with you, and send it out and ask for a sit down, right? So the collaboration should involve, you know, the purpose of your partnership. Should address HIPAA and core issues, that data sharing culture. You can use this presentation as a step-by-step guide if you like. And the last best practice that we found, or one of the last ones we found, was CAD versus RMS data versus arrest-only data. So using arrest-only data is not efficient in showing total contacts with police, particularly in this part of the country where arrest is minimal with mental health individuals. So using records management data to include incidents, arrests, and events, field interviews, represented a higher quality of analysis, including CAD data when possible. I know it's dirty, I know it's icky, but try, okay? Including CAD data, how many times someone called police, or were they involved with police, how much time we spent on those calls, combined with the reports, yielded the most comprehensive analysis. So even if your CAD data is dirty, it still provides value. So I encourage you to take a look at that. All right, so what are the next steps? We have 2 more slides. We're wrapping this up. What are you going to do? Now, here's the thing. You could take a listen to this presentation. We have a bunch of attendees here right now. We have a bunch of people who are going to listen to this afterwards. You can listen to a webinar and say, yeah, that's pretty cool. I wish we could do something, and stop, right? Or you could say, no, I'm an action finder, and I'm going to create action in my community. If you're that action finder, if you're that catalyst of change kind of person, here are some next steps for you. Ask yourself, what do the frequent utilizers look like in my community? Print this out and share it with your command staff. If you're the command staff, share it with your analysts. If you're the command staff or analyst, share it with your clinician, and all start a conversation together, right? So what do the frequent utilizers look like in your community? What partnerships currently exist in your community? What partnerships do you want to grow, right? Who could you bring to the table that would be perfect for the bus, right? Get the right people on the bus. What needs to happen for you to better serve this population? Now, think about that question. What needs to happen for you to better serve this population? You are responsible. I've seen analysts say, there's nothing we can do about that population. That's not true. We are the masters of the information. We are the ones who can ignite this, right? Chiefs, commissioners, deputy chiefs, whoever you are on this call, you are the leaders. We are the leaders together, and so we can impact a change. What data do you have access to? Do you have access to your CAD, your records management data? If you don't have access to it, how easily can you get access? There's this funny little thing called Open Database Connection, and if you don't know how to use that, the IAC has some training on that as well, so you can go ahead and look that up, how to connect, have direct data access to your information. What types of analysis would you want to create? Take that list and think about what would be most helpful in your agency. How could you create some efficiencies? Who would get these analyses? Do you have a clinician to talk to? Do you have a team in your agency to talk to? How often should they receive this information? Do you know what services exist in your community? Do your officers know? I mean, think about this. Think about doing a little research, maybe going out in your community and really understanding the key resources that exist in your community and putting them on a laminated card and giving them to your officers. So each of them have a little laminated card of all the opportunities that exist, all the resources that exist that they can utilize while out on the street. What gaps, I mean, true gaps exist. So when you're doing your study on services, you're going to identify some gaps, but you may identify some services that you thought were gaps, and we're not. So thinking about what real gaps exist, and then going back to the first part of this is what partnerships need to be put into place in order to fill those gaps. You can ask yourself, have you attended a sequential intercept mapping training with your partners, right? And maybe you have, and maybe you did nothing afterwards. So how can you reboot that partnership or begin that partnership if you haven't already? What strategies do you have in place? Are they working? Do they need a little bit of tightening up, right? The key question to ask yourself, whatever role you are, if you're a clinician, if you're an analyst, if you're a chief or a commander or a lieutenant or a captain or whoever you are, a dispatcher, whoever you are listening to this call, the key is do something, right? What action will you take today? Most certainly, you want to take some action. Okay. I hope I inspired you to take some action. So we did a lot today, right? We looked at a lot of different things. We looked at understanding the problem. We dug really deep into understanding the big picture problem. We talked about building this data sharing culture and how to do that. We talked about the data that you need, the key areas of analysis that would be helpful. We talked about building that coordinated system of care, identifying gaps, and shared some best practices with you. Now I'm going to take a moment to see if I can figure out how to get here and look at some of the questions. And Kyle, I actually can't see them too well, so if there's an opportunity for you to read those questions off, I'm more than happy to spend a few minutes sharing that.
Okay, so the first two are kind of similar, but mostly they are asking what kind of HIPAA restrictions are there, if any, that relate to maintaining databases with personally identifying information of frequent utilizers.
So it's interesting. We actually had an attorney who worked with us, and so what we had to do is we had to have a third party look at the data who was both HIPAA and CORI cleared. So when you combine the data sources, you have to both be HIPAA and CORI cleared. The clinicians, if you have them in your agencies, are both, right? So they can look at the HIPAA and the CORI stuff. Analysts who are police hired analysts will likely not have access to the HIPAA data, and maybe you don't need it. Maybe you just want to know, who are frequent utilizers and share that HIPAA information with your clinicians, because they're the ones that are going to actually do that kind of work with them. So I would say police departments are not always privy to that information. That's a regular battle, right? There's some arguments that they should be and others that they should not be. So that's all being teased out right now. But I would say what we did is we had that third party vendor who signed both of the agreements. We both hospitals and us uploaded our data, and then we actually, for the sheriff's office, hired another party college to actually analyze all the data. So I hope that's helpful.
Okay, this is kind of in the same vein. We are having some challenges with being able to access or share mental health data due to HIPAA privacy concerns, which makes it trickier to identify top utilizers and the reasons for usage. Mm-hmm. So there's a similar struggle with sharing criminal history info with non-LE, so for example, fire and crisis networks agencies. Mm-hmm. Concerns have been raised over sharing crimes, arrests, etc., history with non-PD folks. There's even concerns about identifying individual persons' addresses and whether we have to only do so for individuals who agree to have their address listed so that law enforcement knows ahead of time that there's a mental health person at this location. But only doing this for those who agree will not necessarily help us reach our highest utilizers. Do you have any suggestions for how to bridge these data sharing issues?
Yeah, so the biggest thing that we found is that we needed to get everyone to the table. We needed to figure out what CORI information could be shared. And it was really much more open than I thought it was, in terms of what we could share with the clinicians. So I think being able to, sit down, have data sharing agreements with folks that are really outlined and detailed, and you can look at Arnold Ventures. They have a lot of language around this as to how to form those relationships and form those partnerships. But I will say, as a police agency, you already have access to the data and the information. I had the pleasure of looking at the police information, and then when we integrated the other information, it really wasn't that much different. like when we looked at the EMS stuff, it really wasn't that much different. We knew who the frequent utilizers were because they've had multiple contacts with our police agency. So many people are fearing that they don't have all the data they need to do the analysis, but quite honestly, you have a lot in all of your police data. So I want to put that out there because I feel like a lot of analysts stop right here and they say, well, I don't have access to Corey stuff, so I may as well not be involved, or there's nothing I can do. But I argue that having been a person who's been involved in both sides of it, it really isn't that different, and you do have access to that stuff. The questions to really ask yourself is, what HIP data would we even want to look at? And it's likely not a lot. The HIPAA information that we wanted to look at was the cost. We wanted to know, we wanted to be able to identify how many times that person hit the mental health system, how many times they went to the hospital. But we already knew how many times they went to the hospital. So it was really a matter of like the cost analysis. And we didn't want to do the cost analysis. We had another party do that cost analysis who was HIPAA cleared. So I hope that's helpful. I think that's a little scattered response, and so I apologize if it is. I think you can work together with people with not necessarily handing over data, but being able to create lists and information sharing opportunities is much easier than I think analysts think it has to be, especially with your clinicians. Those are people who are in both arenas.
All right. Before I read this last one, if you have any other questions, now's your time to type it into the chat box, so please go ahead and do that. All right, our last question so far, unless we get any more. Can you share the JDP creative form to help officers?
You know, I wish I had a copy of that. I don't have one personally, but I can find out for you. Let me just write a little note to myself to get that form.
Yeah, we can send that out to everybody if you're able to get a copy of it.
I can reach out to the clinician if he's still there and see if I can get that form for you. Yeah, that was super helpful for the officers, and I believe that was out of Tewksbury, Massachusetts. So I know exactly where to go to get that information for you.
All right. Well, we'll give people just another minute or two to see if there's any last-minute questions. Dawn's got her contact information there on the slide if you need to get a hold of her. I'd just like to share again that you will be getting an email tomorrow from Citrix that will contain your certificate, and it'll also have the link to our evaluation system. Please do take just a minute or two to fill that out because we really do use that feedback. If you haven't taken a look at our schedule to see what other classes we have coming up, please check that out, iaca.net/training. We got several more webinars throughout the rest of the year and some online classes. So there's a lot of different topics there for all kinds of different subjects. So, we have not gotten any other questions, so I think we'll go ahead and wrap it up for the day. Thank you very much, Dawn. I really appreciate it, and thank you all for joining us. I hope everybody got some really good information to take away from today's class. So have a great rest of the day, all.
Thank you so much.